fellowship in this institution, because there is a whole syllabus. It's very well structured, and then I think a lot has changed.
More complete.
Yeah,
Yes.
but I think both have different flavors, and I think in the US even now it's like they say I did my fellowship under this person. Like my sister says I did my fellowship under Shelby, because everybody knows him as a person, and then they expect the fellow to be like the mentor, and that's how it is. But I think there is a changing trend towards a more structured syllabus where you do X number of surgeries, and the mentor doesn't really matter that much. But I still think that the mentor has a very large role to play in a mentee's life.
In the MOS, the Maharashtra Ophthalmological Society, Dr. Jignesh Taswala, who is the present president, they have started the mentor-mentee program. It just kick-started last week. So,
I think every member in this audience is a teacher here, and I think I'm closer to a student than anyone else here. So I'll ask a question to Dr. Himanshu and the expert panel from a student's point of view. Generally, especially since the topic is on cornea and anterior segment, what most postgraduates who finish and are waiting to enter a fellowship, when they ask each other, peers, seniors, the questions they ask is really about how many phaco's will I get, how many PKs will I get, how many LASIK will I get. It's not really the things which you spoke about, and frankly that's what we learn more during the fellowship than the surgical training itself. So what do you feel, sir? How would you guide a student or anyone in the expert panel on what aspects they should look into? What should they ask their seniors when they are choosing a location for a fellowship?
So I think, in fact, I had same discussion last week with my fellow who is down almost a year now. So I think it's a mindset, and not only just that, the communication channels between teachers and students are still not as open. Why should they ask a senior who is possibly, again, as bad student and as naive as that person, rather than there should be a way to ask that teachers. There should be communication to learn. So what they want to learn, that itself is not very clear in many of their minds. And the worst thing is that's not how they ask. It's like, how much cutting do you get? I mean, that's like typical maybe Bombay language, right? Cutting, how much cutting?
You should tell them to go to a barber shop.
True. And in fact, it's like my fellow first day said, I'll dispose the patient, you can carry on with it. I said, you do not dispose human beings, right? I mean, that's the mindset sometimes we have, dispose patient and cutting. Well, we need to change that mindset. We need to possibly show them that what they get in their life, being with some people, being in a system, as Dr. Shri Ganesh said, is much more than a few cases here and there.
I got to hear a lot of all this. My son just joined LVP as a DNB resident, so all this is really, what he says is so true.
I just say one thing.
This is a common question. When they ask me how many surgeries will I get, I tell them it depends upon you.
Yes. Absolutely. I think that's the best answer you can give them.
When a lot of people, they say that how much cutting do you get? I give them my example that at RP Center, when I did my PG, we did 1 cataract a month. And at LVP, when I did my fellowship, somehow I managed to do only less than 10 keratoplasties. And I don't think as a surgeon I'm anything bad than what the others are. So I think it's not the number of surgeries, but it's what you see in the, the consultant doing surgeries and how much you can pick up from that. I think the fellows or these PGs, they have a feeling that if I do 100, I'm a boss, and if I do 10, I'm nowhere. So I think that concept is to totally change, it's how you do it and not how much.
And they have to be like a sponge. They have to pick up things from.
The quantity is not important at all.
That's why my question was around that, in the sense that everybody asks about numbers. So what do you feel a postgraduate should be asking when they decide where they want to do a fellowship as per their interest and other things? Sir?
I mean, the question basically is, whenever you are finishing your MS, you're investing another 2 years of your life. You want to finish that and you want to start your private practice, or you want to join. When you join, every institute asks you how many cases, because even when we take an interview for somebody who's joining, we ask your CV, how many cataracts you have done, how many PKs you have done, how many DSECs you have done, can you do a DMEC? Not everybody going in out of fellowship is going to be competent. There is going to be a learning curve for all of us, even once we join as a fellowship. But what is important is have you understood the basics of the specialty? Are you managing the patients appropriately? Every surgeon goes through a learning phase. Even that fellow who finishes his fellowship has to go through a learning phase. There is going to be a basic minimum number for you to get competent, which is there, which could be 5 for somebody else, it could be 50 for somebody else, which varies from individual to individual. But I don't think we'll be able to put a fixed number for everybody to say, okay, you're going to be competent in this number of cases. But even if you do few cases, but if you do it in a proper methodical manner, you actually come out much better as compared to doing 100 cases without supervisions and learning the wrong thing. Because unlearning something which you have learned is more difficult than learning in a correct manner. The second thing that I would probably want to emphasize is you learn more from watching surgeons struggle than you learn from watching an expert surgeon. You see a phacosurgery being done by the best surgeon. You feel it's such a simple procedure. 5 minutes surgery is done. You see your senior colleague operating, then every step can have a problem. Your incision can have a problem. Your access can have a problem. So you learn. I tell all my fellows, you will go for all the therapeutics or all the surgeries that your senior residents or your senior fellows do. You will learn more by seeing them struggle, because once you see them struggle, you come back to the consultants who are, and you see what is different that the consultant is doing as compared to the fellow, or you will be asking questions as to why he struggled and why you didn't struggle.
So how about just asking, I mean, are we just sent to camps, collect surgeries, and then, keep on doing them during our fellowship? Or is there some supervision where, you are, like I was hearing Dr. Sirisha talk, I mean, where your hand is held and you're made to do surgery. So maybe it requires, 10 surgeries, and one student spends those 10 surgeries on just, how to make a tunnel, for example, or how to do lamellar dissection. So they have spent 10 eyes, but this is the only step they have learned. So it maybe with 100 also you may just reach up to the
I think it's an
Rexes.
ongoing process. Even after 100 you may not really be so competent.
Supervision, I think, is...
Yeah, I think that point comes when you get that confidence and you start learning yourself. If today even YouTube channels, there is such good surgeries that are seen. I mean, it all depends on where you pick up what
I just have one additional point from what Dr. Bhaskar said. I keep telling my postgraduates as well as fellows, you do wet lab practice every day, even if you've become good at doing SICS. Because once I heard Dr. Tan, from Singapore, he said he does wet lab practice even today, after doing so many surgeries, because I personally follow that. So for every surgery, I was when I finished my PG, I was an ICC surgeon. So I've come a long way. I mean, I'm sure most of my people in this age group, we've done ICC, we've migrated to ECC, then phaco, then PK. PK, nobody was my mentor. What I just seen as a postgraduate, I started PK, DSEC, DMEC. So everything, you can do it. Like you said, there are so many YouTube videos, there's so many ways to learn, but the best way to learn is do wet lab practice, because you cannot sacrifice a human eye for that.
Absolutely. Yes, Dr. Harshardhan.
Yeah, good afternoon.
If you could set it up, the next speaker.
Yeah, good afternoon. I think fellowship is an ongoing process that you rightly mentioned. It's basically starts with your structured fellowship in a particular institute or under a particular doctor or a professor, and after that it continues in your own institute where you are working with another senior doctor who is doing certain things which you are following and picking up, and then it works furthermore through your own practice. As you start learning from your mistakes, you start analyzing and auditing your mistakes. When you go home, see your videos again. And lastly, it also comes from all other doctors around the world through, as you said, YouTube channel. I can be a fellow of Dr. Basak even staying at home. So that's how today it should evolve. And we should not label somebody as you are a fellow of LV and you're from this institute. I have known people who have worked for 3 months under some doctors and they have become big faculties in their own fields.
We can all be ekalavyas.
Just by 3 months of fellowships, they can learn. They learned many more things after that. So that's
so true.
That's what
I think to answer the question, what should a trainee be asking? See, I think observation is the first step to learning. So you observe and then monkey see, monkey do. So if you observe a bad surgeon, you'll pick up all the bad habits and then it becomes very difficult to change that. If you're observing a good surgeon operate, then you learn the principles, you learn the techniques properly. So the first question a trainee should ask is, will I have opportunity to observe the surgeon? Because some places it's so busy that the fellows are so busy doing camp work, other work and all that, they don't get to observe good surgeries. And then they're just given surgeries to do. They have not observed surgeries, so how can they, practice? So that is one thing. That's the first thing, whether they can observe good surgeons at work. Second is whether they have access to resources, like wet labs. That's very important because they will have to practice on. The third is whether the training will be supervised. Many of the big institutes, there's no supervision. They just give you the case and say, do it. And the trainee does whatever he wants, and whether he's messing up, whether he's doing something wrong, there's no supervision. So third is whether I will be supervised. That is another thing which has to be, and whether there's somebody to correct me. If I'm doing something wrong, is there somebody to correct me, correct my steps? It is so important because small things you tell them, it makes a big difference to the surgery, makes a big difference to the confidence. So more than the number of cases they do. Number of cases probably is the last thing that they have to look at.
Points well taken, sir. Very valid.
Speaker, Dr. Sheetal Brar, who is a senior consultant in Netradama Eye Hospital, Bangalore, and amazing surgeon with every possible award in her basket. And she's going to be talking on the refractive surgical training program, how it unfolds exactly for 10 minutes. We're running very late.
Good afternoon, everyone. Thank you, ma'am, for the kind invitation. And I'll be talking about the refractive surgery training program and how it unfolds. So I'm sure everyone here would, most of you would agree with this, that refractive surgery is probably the most lucrative branch of ophthalmology. And why so? Is because from the surgeon's perspective, the procedure appears to be simple and less complex, like doing a PRK or LASIK has few steps, is not as difficult as a cataract surgery. Also from the patient's perspective, the results are pretty instant. The patient sees 6x6 most of the times, is very happy, sends you thank you notes, you are very happy as a surgeon, and also if you're a successful practitioner, then you have good revenues also. But on the flip side, if your refractive surgery goes bad, patient is unhappy due to post-op complications, halos, glare, has to go back to glasses, and so this can be quite frustrating also. Patients put bad reviews, and sometimes you can find yourself in a lawsuit. So why this unfortunate situation is there? So the current status of refractive surgery is such that refractive surgery has actually made an evolution more towards practice with less interest in formal education. And this is because most of the residency training programs, not just in India but also abroad, do not include refractive surgery as a subspecialty. However, as surgeons and from patients' perspective, the refractive outcome is actually the end point of all the procedures that we do, the cataract surgery, corneal grafts, RD surgery, glaucoma surgeries, etc. So recently it has been emphasized by Refractive Surgery Alliance group that it is a high time that refractive surgery should be called, should become a own subspecialty, an own specialty, not just a subspecialty, and there is a formal need of formal training, supervision, and qualifications has been increasingly recognized. The surgical techniques itself involves short learning curves, but the theory underpinning refractive surgery actually can be quite vast and complex. They need to understand the basic concepts like abrasions, biomechanics. There are a lot of things to refractive surgery which actually need knowledge and in-depth understanding. So if a student wants to gain exposure in refractive surgery, has interest in refractive surgery and wants to develop a career in this field, I think there are essentially two types of approaches. One is a long-term approach, another is a short-term approach. In the long-term approach, most of the times they can enroll in a long-term fellowship, which typically lasts from 12 to 24 months and is a part of a cataract or cornea or a comprehensive fellowship program. And or else it could be an exclusive refractive surgery fellowship which could last from 3 to 6 months, focusing only on refractive surgery. In the short-term approach, they can go to different surgeons to observe for 1 or 2 weeks. They can attend refractive surgery workshops, wet labs at conferences, and it can also be more of a collegial approach where they discuss their cases with their peers and learn from their experiences. So in a typical long-term fellowship, I'm talking from Netradama perspective because this is how our program is. the training offered is in a structured manner and in a step-by-step approach. So students have the opportunity to learn from experienced refractive surgeons, and this can be highly beneficial. But when you look for a training program or a fellowship, it's very important to choose your mentor, what you see in a mentor, and then how you apply. So while looking for a mentor, it's very important that you be sure that the mentor can provide instruction in all aspects of refractive surgery, not just one. So say somebody is just doing PRK or LASIK, but they are not doing ICLs or presbyopia corrections. So you cannot really say that they know everything about refractive surgery, because every type of refractive surgery has different principles and techniques are different, so they need to understand all that. They also should be active in research, and they should be well known, dedicated to understanding of diverse technology, and should have significantly contributed to the field. So in our institute, we have a phased structured training wherein it's a typical 18 months program, and I'm sure at other institutes also it's pretty much 18 to 24 months. In the first 6 months, the student gets familiar with the basic procedures and equipments. So they are posted in optometry and refractive surgery workstation for the first 6 months. So they get familiar with the basic techniques of refraction, retinoscopy, contact lens workup. They need to read topographies, abrometry, dry evaluation, corneal biomechanics, etc. And they also learn the basics of the lasers being used in the institute. In this phase itself, they also are posted with the consultant, where they also learn the right way of doing a preoperative workup, proper way of taking history, understanding the different aspects of history taking, such as why occupation is important, the medications, understanding patients' needs and expectations, etc., how to do a proper ocular examination, suitability, and also decision making about a particular type of procedure, and choosing the best procedure for the patient. So this is a kind of a decision making tree for myopia that is being followed in our institute. So I'm sure other institutes also have their own algorithm for deciding the best treatment for the patient. So what happens is, using this kind of an algorithm, the student is given the exercise to use this. So basically they have a case scenario. So they use this to see which is the best procedure. So when they use this kind of algorithm again and again, so they don't have to then remember it, and because it gets incorporated in their mind. So in the phase 2, the student observes refractive surgeries in OR with an expert surgeon. This lasts for 6 months again, and sometimes it also overlaps with the first phase. So we start their observations from the 3rd month itself. So as sir already said, that observation is the first step to learning surgeries. So they learn the right technique of doing different steps, like how to properly remove the epithelium, how to lift a flap, how to settle a flap, and not just the right way of doing the technique, but also how to handle problems. So if you have a OBL, if you have a black spot in smile, with all these issues, suction loss, how to handle these. And in the last phase, which is phase 3, they undergo hands-on supervised training. Again, number depends upon their own skill, but we have a certain number. So this is the last 6 months of their training, where again, the first procedure that we give is the surface ablation, followed by microkeratome LASIK. Again, the procedure is divided into its individual steps. So only once they are comfortable with the initial steps, they are giving the final case. So in the same way, femto LASIK is taught, and finally smile. So docking, identification of planes, dissection, and then the full case. So I think the main advantages of mentor training is for the student, the right way of learning patient selection, decision making, preoperative workup, counseling, surgical steps, and also postoperative care and patient management, which is so important, because it's not just that every patient is going to be happy. You can have unhappy patients. If you do a perfect LASIK, your patient can come the very next day with flaps dry or DLK or something like that. So only if you are doing a long-term fellowship, you will actually learn to even manage the post-op problems. And research. This is again so important. Long-term training programs do offer research opportunities, which is important to understand the concepts in depth, such as very simple thing like JRS standard graph. So this is the way of reporting the refractive surgery outcomes, and also vector analysis for astigmatism. So in short, so I think this is the last slide that summarizes my whole talk. The mentored fellowship is like a user guide. The user handholds you and takes you through the whole process, so it becomes much easy for the student when they pass out. And versus the short-term approach where you just do some observations or workshops, which is like solving a jigsaw puzzle and is like learning in bits and pieces, probably may not be a very effective way to learn. So in short, there are no shortcuts. Conclusion, so with the growing demand of the patients and their awareness about refractive surgery, it's important to include refractive surgery or at least part of it under postgraduate ophthalmology curriculum, and supervised trainings and fellowship in reputed refractive surgery centers with well-known mentors is probably the best way to negotiate learning curve and gain confidence in refractive surgery. So this is how my program, my refractive surgery program unfolded, and I have learned so much from my fellowship, and so many other fellows every year, 10 to 12 fellows, they get trained in this way, in this phased manner, and once they pass out, they are actually very confident, are able to start off with their own practice. So I think this is the best approach.
Great, absolutely wonderful talk, Dr. Sheetal.
Thank you.
I had a question for you. Refractive surgery is a very demanding procedure, and the patients themselves have expectations which are sky high. And even if you have a patient whom you have done a surgery perfectly, they can still come back to you with complaints. So in such a scenario, when your fellow does the surgery and God forbid there is a complication, so how is the patient handled, and how do you actually give them the hands-on? See, teaching them technology and pre-operative workup is still okay, but when they actually handle the patients and suppose there is a complication, I know it would be supervised in the beginning and you would take over, but still, if there is a problem which lingers on and that compromises the patient's vision in some way, how is it handled? And because of that, what are really the number of cases that you can give them so that they gain the confidence of going back and doing it alone?
So first of all, cases done by fellows are always told to the patient that these cases will be operated by a trainee surgeon, because we have a kind of 3-tier system. So I think sir can explain the system, how it works here. Because he created this.
See, we have a 3-tiered system because we have the senior surgeons where the cost is the highest, because basically we, irrespective of the equipment, we believe that the skill has to be paid for. So senior surgeons have the highest, and then you have next is the junior consultants who are just, have experience but not a whole lot of experience. So that's a different level. And then the third level is the trainees. So the difference between the senior surgeon and the trainee, the cost can be almost 50%. So there are many people who look at, who want discounts. With refractive surgery, they want discounts, they ask for discounts. So people who cannot afford or who want discounts are slotted accordingly into one of these tiers. So people who say, I want the best surgeon, I want the best equipment, I want the best results, okay, I'm willing to pay for it, it's fine, whatever it is. So we have a 3-tier system which works well.
But it's not that the surgeries done by fellows are
fellows
not supervised.
Bad. Yes,
every
agree.
surgery
I
done
agree.
by
We
the
tell
fellow
them
in our institute
because it is your responsibility. That's why we have the structured program where they observe, learn, they do the refractive workup, they are very thorough, and they also do wet labs. Yes. And then only after the wet labs, when they are confident, then every step is supervised. Suppose they are not able to find a plane, then immediately we take over. It's not that we make them struggle.
We don't let complication happen.
Because this is so different from cataract. Here in a patient who is already 6'6" and...
See, the worst thing that can happen, of course, the first thing that can happen wrong is getting the refraction wrong.
Yes.
But that, it is always verified by our optometrist and by the supervising surgeon. So once the refraction is correct, the other things like centration, docking, if they are not done it properly, you can always go back and do it. Lifting the flap, if they are not able to find it, you take over. You show them how to lift the flap. Centration is usually automated.
So a special consent is taken from the patient that it's done by a trainee?
They know that the surgery is being done by a trainee under supervision.
So is there a chance that these patients, they are not done for free, right? Even if they are paying a single rupee, you are responsible for it, right? So you can still go into a lawsuit.
So we don't leave the fellows. We are there always.
See, that's why supervision is so important, and the patient knows that this doctor will be there supervising the surgery.
Right.
And they agree for it because they get a big discount and they are happy. See, if they get a good result, then they tell their friends, hey, I got it done at 50% of the cost.
Right.
So that's how we
get
have
that
cases
tired
for
also.
fellows and who can do surgery.
You know, one thing that makes a lot of difference to the patient is that when I counsel them for my fellow, I tell them I'm responsible for it. Your eyes are my responsibility. When I say this word, everybody, you know, they're very fine then. But somebody has to reassure them.
Right.
See, what is wrong is that doing ghost surgery in the sense that you say, hey, I'll do it and then somebody else, that's not ethical also.
Yeah.
So it is best to be open with them, tell them, take a consent. We introduce them to the surgeon, the supervising surgeon. They're comfortable with it and it's fine.
I also tell them that during the training, I will be speaking to the doctor. So,
Yes,
but you should not, you know,
you
that
shouldn't
not
get
you
disturbed
should just
because of
focus
that.
on what I am telling you. So actually, most of the times I am talking to the surgeon, to the patient, and
I think
you know,
well, your question first for the first speaker, no, or the first topic, it's almost answered by her now by her talk. A long-term fellowship. Whenever we offer fellowship, most of us are offering at least 1 year or more. This is not like a short-term 2 months FACO training, where the candidate also will be focusing on only the number of surgery, because there the technique is almost same for almost all the patients, and only you learn the technique and you go out. But a fellowship in a subspecialty is entirely different. What Dr. MS is dead against giving any short-term cornea fellowship. He used to tell anybody who can do suturing can do PKP. With 10-1 nylon, if you are well versed with doing suturing, you can do PKP or later on any other surgery. But what they have to learn during that 1.5 year is to choose the patient properly, to choose the surgery properly, to plan the surgery and manage the problems, and most importantly, when not to touch the patient.
Absolutely.
All these things they have to learn, and that can be learned only by the process. So that's where the fellowship is entirely different.
With refractive
Yes,
surgery, it is different because there are very few fellowships in refractive surgery, in exclusive refractive surgery, because most people think, oh, refractive surgery is nothing. You just get linked to a center, you go and do it. So most of them are weekend refractive surgeons. They say, I do retina most of the week and then weekends I do refractive surgery, but that's a very wrong approach. That's why now I think they've started the World College of Refractive Surgery, WRCS, Guy Kazarian and a lot of them. It's an international organization and they're looking at having accreditation and curriculum. I'm also part of it. So it's a very structured program and you get certified to be a refractive surgeon. And then patients will ask for this accreditation and certification when they come in next. Because otherwise, anybody can do refractive surgery. A PRK is just pressing the foot pedal. You don't have to do anything. The optometrist does the refraction. Now you have trans PRK. You don't even have to remove the epithelium. He will focus the machine, you press the foot pedal, and then you get your charges. But that is not the correct approach.
Yes, thank you so much. Thank you,
everyone.
Yes, let's go on to the next topic. Dr. Samar Vasak sir, he would be speaking to us on the cornea surgical training program. Looking forward to hearing you, sir.
Just a quick question, sir, while sir is setting up. When a candidate is selecting a fellowship program, especially in refractive surgery, considering the costs and other things involved in setting up a refractive practice, should that be a practical consideration, or should it be even a question in their fellowship interview, whether they come from an area or a location? Maybe if they're place like city like Bombay, they'll have 100 practices to go to and do their cases. But if they are from a slightly smaller town or city, should that be a relevant question for them to be actually practice refractive surgery after they go back?
See, in most of the bigger cities, they will have access. So they can get kind of attached to one of the refractive surgery centers, take their patients and do it. But they need to have the training. And in a smaller place, maybe a tier 2 city, then there's opportunity. If there is no other refractive center there, and if they are very well trained and they're able to deliver good results, then they can even invest. Like I invested very early in my LASIK machine, probably my 5th year of practice or so, when I could little afford it, but still I was able to deliver good results. So you can always, and sometimes you may not be able to start refractive surgery immediately. There are many fellows of mine, but they've learnt about it, and then the phaco practice picks up. After some time, they earn enough to take a loan, and then they put up the machine.
And Shreyas, that's true for all practices, I guess. Even for retina, you cannot just, buy, full-fledged machine all by yourself, perhaps initially. So I think that should not be a question.
Okay. Yes, sir.
Is picking up.
Yes, sir, please.
Thank you. My understanding was like the heading was training of the trainers. Here I saw the heading was the PG, post-PG fellowship program. So I have little to say because already Himangshu's follow-up discussion has covered everything. But I want to share a story with you. The story that recently we have a MOU with Government of West Bengal to train for corneal surgery, keratoplasty and eye banking, and the course designed by the government, and it is for 2 weeks only. And that among those 2 weeks, we have been given 2 days. 1 day for eye banking and 1 day for keratoplasty. So a batch of 9 ophthalmologists came to our place. And this happens this month only. May first week. Age group 35 to 60 from different government medical colleges came for 2 days, as I said. The goal that this colleague will go back in respective college and train the PGs or SRs to start basic keratoplasty procedures. The course, as I said, designed by senior ophthalmologist of government institutes and SPO, state program officer of the health department. We had 2 days session, and as per their guideline, we cannot choose the guidelines. And then I interacted them for 3 hours. That was my part. And other colleagues were there, eye banks was there, everything. So I did a survey questionnaire during lunchtime. I gave them this type of questionnaire. So more elaborated, but major questionnaire: how many patients you see in OPD? Do you have functioning slit lamp? Microscope, whether functioning or out of order? Any exposure to the eye bank? Have you ever seen any live keratoplasty? Surgical management of open globe injury, chemical burn, etc., etc. Availability of different kind of sutures and scope of corneal scraping, basic cornea minimum surgery. Why I ask these questions? Because sometimes we get patients from medical college, even from RIO, the corneal tear rupture repaired by either Prolene or 80 Vicryl. So I have asked this question. I have met training of the trainers, not for fellowship program. So in 4 medical college, what I've learned, slit lamp not there or malfunction. Himangshu, you did not talk about anything about clinical aspect. You have thought about your institute and whatever discussion is going on about the private institute and so to say the high-end higher institute. Nobody is talking about the government institute, which are generating actually more than 60% of total PGs and fellows, SR. In India, every year, cornea fellowship and SR, I have calculated because I have to give lecture in other parts, 72 in number every year from all private and government. You know that government part is huge, more than 60%. That's why I am putting this question. 2 colleges, microscope is not there or not working for 2 years. They do cataract surgery only by SICS. 6 of them have never seen keratoplasty surgery live. 4 of them have not seen any amniotic membrane. Ruptured debris, they do not have access to correct suture. They know that 10-0 nylon is the suture you required, but when they ask, only supply is probably 10-0 Prolene or 80 Vicryl, that particular day or that particular week or that particular month. The same lesson what Srisha was telling in the glaucoma group. So when I learned, we take fellowship 3 in my in our cornea department, 3 or 4 in a year. So many candidates, they do not know how to use the slit lamp. So the same answer, during their PG strip, they do not know how to handle a slit lamp. The many candidates do not know how to use microscope. They have never seen a keratoplasty. They do not know during PG strip that they do not know how to do a corneal scrape, etc., etc. How to give wash in a chemical burn. Because there is no scope of such kind of learning in those medical college where postgraduate training is going on. You know that we have application from RIOs and Premier Institute of India. After doing 3 years SRship in cornea, they have asked for fellowship. We have 1 to 12 months to 18 months fellowship program depending on the skill. I asked them, why are you asking for fellowship? Because you have learned in such a big institute. This is a bit, sir, we have not learned anything during the surgery, during those SRship. This is the government scenario. These are truth. So, to my mind, moral of the story is cornea surgery training of the trainer should be need-based. Basic, intermediate, advanced. Basic, it is just like what is fellowship program, what you are talking, fellowship. That is the basic. Eligibility criteria, duration, you may think about, and based on their previous knowledge, it may be 3 months. Because the government of India, initially what Dr. Revati was saying that Dr. MS or whatever, for government medical college, those who are interested in learning keratoplasty because there is a huge need, they have reduced to, we need a trained corneal transplant surgeon, the certificate for HOTA transplant center. So 3 months, they reduced from 12 months to 3 months because they can only give leave to their staff for 3 months only. So that's why 3 months to 12 months, 18 months, 2 years, whatever, based on pre-assessment criteria, and you need some pre-assessment criteria and discussion with the mentor. Second one will be the intermediate. They learn more complex surgery like DALG, DISSEC, combined procedure to learn advanced contact lens service. And eligibility criteria might be, again, predetermined, and pre-training knowledge, 1 to 3 months might be, based on pre-assessment criteria and discussion with the mentor. And third is advanced, maybe for 3-4 days only, up to 7 days, because they know everything. Like people come to me, or I go to some places. We have a typical 3.5 days program. I do across Southeast Asia region every year. Last 2 years I could not go, but I used to go five countries. This is my international visionary voluntary service. So I have 3 or 4 my colleagues, 3 from US and I am from India. So I cover Southeast Asia region, and we usually make a program, 3.5 days, DISSEC program, DMEC program, Boston keratoprosthesis. These are advanced because they know all basics. They only need little help. And we always say that we will go to your place because it will be your patient. You will be using your OT. You will be using your instrument, and language barrier will not be there. We will be doing 1 case, and you will be doing 8-9 cases. So they gather like this kind of training we are giving since 11 years, except last 2 years. And it is going good across the country and also in Southeast Asian region. So again, the only thing we want to emphasize, you must know the rescue operation first. Whatever discussion is going on, unless you know the rescue, for DMEC, you need very good DISSEC surgery. For DISSEC, you need very good PK surgery. Or DIALC, you need very good PK surgery. So course detail based on pre-assessment criteria, need-based, maybe customized. Wet lab, live, near-live surgery, demo, YouTube videos, hands-on in selective cases, interest of the trainee. All master trainers and training institutes have their own curriculum. We have learned this period. Last word, the trainers should have infrastructure. Those who are coming to me like this, those 3 hours is a total loss for me, Because I know, but it is a government order, I cannot decline it, to start training, and they should have ready to take students for further training for their institute. Thank you very much.
Thank you. Thank you so much, sir. It was really...
Other perspective.
Yes, yes. And it is so true because we have gone through such kinds of training also, and so many of the doctors who come to our institute also for, as consultants, and when you ask them about their past, how they have actually gone through their residency and their fellowship programs, many times this is so true. And then you finally know when they actually deal with patients, especially in private practice, it becomes a little difficult. So it's so important. Lovely talk, sir. Dr. Swapna, you want to say something?
It is an eye-opener because, even like when I started long back, my PG, there was a microscope, but it had no light. So there was another person who used to hold a torchlight. And we had to look through the microscope.
And even this one hospital, in government of West Bengal, I was sharing with somebody, government has a mindset that each district will have a medical college and will have postgraduate education also. So right now in Bengal, it is almost 24 medical college. And each medical college has got only 2 consultants because no one is ready to join in government medical service. So only compulsory 3-year SRship, because unless they will have to give penalty of 50 lakhs or 30 lakhs, whatever this. You know that one senior SR, after PG from one of the institute, SR, and one consultant is there, assistant professor. Professor level, they hire from here to get MCI permission. Now I'm telling the truth. The problem is with that one person go leave, 2%, he has to see his OPD 500 patient with a long stool and torchlight. Even it is in 2022, it is practice now. So what you are talking about cornea?
Absolutely.
But there was another thing also. My HOD, she was a Rotary Club member, and she was so resourceful. She got all these people to get us, all the an HFA machine, YAG lasers and all. So I think the HOD also matters a lot. The government
but
never...
in many government places, it's very difficult to get equipment. And I remember doing a therapeutic PKP on a one-eyed patient in one of our peripheral centers without microscope at midnight. I remember doing it myself.
You know that the government has another thing in their head, that you have to do 600 cataract surgery in a year per ophthalmologist in government setup per year. So they have to do that, otherwise they are transfer posting or they will have a bad posting, punishment posting, all these things are there. So it is not easy to make this solution. We are in a private group, we know the solution might be easier, but these are only few institutes in the country.
Absolutely. Thank you so much, sir, for the great insight. I'd like to invite Dr. Somshila Murthy. She's the dynamic cornea surgeon, HOD of LVP cornea department, and she would be speaking to us on follow-up evaluations and assessment.
Thank you very much. Very good afternoon. And I'll try my best to stick to the time. And so I just realized, in fact, I just made an edit on my first slide, that it's not training the trainers, but it's sharing with the trainers, because there aren't too many people to train the trainers. And also, all of you are experienced trainers. So I talked to Chitra about exactly what would she like me to talk about, and what exactly are we planning to do in this session. So it was supposed to be to train the trainers, but I think almost everybody has a lot of rich life experience if they don't exactly have it in this area. But it's a lot of common sense also. So I thought I'll just take you through literally the LVP model. So my topic was about the follow-up evaluations and assessments. So say supposing that with great hardship, they have come to join in for the fellowship and they have joined. And once they're in the fellowship, how do you evaluate them and how do you assess them and keep them engaged throughout? So how to assess? So I'm just restricting myself to the cornea fellowship, but it is pretty much true to most of the fellowships that we have at LVP or other places, that a fellowship is a structure that cannot be a purely formalized kind of a learning system. It's not like a management course or a school where you can give assignments and, it's totally different and dynamic. But it has several components. I would say from the top of my head, it has a clinical component, which I mean both clinics as well as surgical, of course. And then it has academic. And then, of course, there's research, which we want our fellows to do. And you want them to be a good doctor. I think I would flip the order. And good doctor, I'm sure Himanshu, Avinash, a lot of us would agree that we want good doctor first and foremost, and then the other things will obviously fall into place. So like our chair always says, the 3 H's, you want head, hands, and heart equally for all our doctors, all our fellows who come out. So learners need endless feedback. They don't need endless teaching. It's not enough to keep on teaching them. So they need more of a feedback. And because they're very young, so they lack the experience or the insight. And I can give you an example of what I mean by insight. Insight means that very often we have fellows who have trained, and they may have had very strong component of cataract surgical training when they come for the cornea fellowship. So they feel they're very good cataract surgeons. And they are not, they say, oh, we know cataract surgery, now next level, we want to do the PK. But when you look at them, you see that they have learned a lot of bad habits. So they don't have the insight that they're not good surgeons. And that's detrimental for their training. So they have to unlearn the bad habits, if they've especially picked up surgery elsewhere. Shreyash, you know that we keep saying that it's better to come in with a slate which is, clean rather than a filled-in slate. So that's the only way you can follow the leader by these ducklings. So there is another concept of expectation versus reality. So when we want a passport photo, we really want it to look like this, but then it usually looks like this. So the expectation is when these 3 bars that I've put here, and is that we expect that our fellows should have about a 50% component of the clinical stuff, which is both clinics and surgical, and a very good, robust, at least 30% of academics. This is purely because of the time. In other fellowship, it can be balanced, but we have a very busy clinical workload, and at least 20% of research component. This is what, at least in the cornea fellowship, because of the time, effort, we want this. But what the fellow wants is maybe 90, I would say 99% should be clinics, especially surgical could be a good 78% of that 99%. One more example is very recently, we were in the interviews for the incoming fellows, and one question I asked is, what do you expect, why do you select cornea and why do you select LVP? So for cornea, they said, like Miss World answers, we want to do this one. But why LVP? It's because the surgical hands-on is very good. So that is like 0. So that's the incorrect answer. So the fellows want 99% of the clinics, and they want, academics, yes, but somebody else should teach it to them, and research, So probably the balance of that would be more about 70-80% of the clinical volume. That's because of the volume we have. We have a huge volume in all centers, whether it's private, public, wherever you look at. And also a good 20-30%, yes, academic sometimes does match pretty well, because thanks to our education initiatives from our education team. And sometimes you have a good balance of research also. This bar could be slightly different, but this is what we have in cornea. So this is the reality that we have. So coming to our fellowship model, as I told you, I'm just sharing the experience, not training anyone. So we have a 3-year fellowship. It has 3 components. It starts off 9 months with the basics, which is exactly what Dr. Basak said. A PG student can come in from any part of India, may not know even slit lamp. Certainly, I didn't know applanation. I had no idea how to do it. And indirect, I had barely done any. So the basics includes a 1-month robust getting experience with all these techniques, and then it includes cataract surgical training and various other components. Then, and they rotate through all the specialties, as well as the core specialty. So they get a good hang of everything. So that 9 months is actually what you're trying to do is compensate for the residency. So this is literally what we're trying to do here, and make them independent for certain basic diseases to manage those diseases. And the next 12 months, they spend a year at a secondary center, where most of the bulk is a lot of cataract surgery and basic training, basic diseases, and anything which is more than a basic disease, like say glaucoma or something, infection, they send upstream to the tertiary care center. And after they finish all this, they come back for the last 15 months for the core subspecialty. So if it's cornea, they come back to cornea, and the last 15 months is when they're totally into cornea. So this has been an excellent model, and we get very well-trained, robust fellows by the end of this, because imagine they've finished literally like a second residency, they've learned cataract surgery, and they've done it, and they've managed a center, and they come back and they go out with the subspecialty of the choice. So which means that it's a lot of multitasking. You have to do multiple things. You have an academic session. There's so much clinical work. There's so many assignments and research, etc. Clinical work comes twice because it's so much of clinical work. And we had a very good experience during COVID for the, not with COVID, but for the education aspect, in the sense that we had so much more education component because there was less clinical, obviously. But that slowly has, it cannot sustain that way, and we're slowly going back to our earlier amount of academics. The fellowship model is centralized, so we have an education academy. The entire team oversees the program. They tie it together. They take care of the basics, which includes cataract surgical training, wet labs, diagnostics, what have you. And also they schedule periodic assignments, rotations for the fellows. And they have a complex system of ensuring that the fellows keep on improving their academics by having them create content on various subjects. They also research and videos, etc. Coming to the level of the individual service, say Konya, for example. So the model we follow is we have a mentorship model, and we found this very successful. Each fellow is paired with a mentor. Mentor is one of the faculty members in that department. So either we can randomly assign the fellow and to the mentor, or more better is to have a deliberate assignment where we match what we think the personalities are like, and that really works. It's a very good handshake in that case. And the mentor has, just like a mentor would be, literally takes the fellow through the ropes, and the initial basic curriculum, like say it's corneal scraping, how to operate on simple cases, corneal perforation and things like that, are taken up by the initial mentor. And the basic curriculum in terms of reading also is covered by the mentor by giving assignments to the fellow, periodically assesses, helps them with wet lab and so on. So that each faculty has one fellow to really train, or it may be more than one, because every year you become a mentor. So 1 to 2 fellows at different stages that they have to train. So the burden of on each faculty is less, and the kind of handholding is better. The fellow connects. So this is the person my go-through person whenever I have a problem. So the fellow connects with that mentor. It really helps. And then in addition to this, we have monthly evaluations by the mentor and head of service one-on-one. There's an online feedback form. And as well as we have quarterly evaluations by the department with the fellows. So the entire department, as well as 3 or 4 fellows get together, one fellow with the entire department, and we give a feedback to the fellow, or the fellow discusses their problems and so on. So ultimately, the goal of this continuous evaluation and assessment is to course correct as required. So somebody has more already, you can push them more into research, more into academics, check more into innovation, or see where their talents lie, if somebody who's already very, very good. Whereas if somebody is not so good, then they need more surgical training. It could be more basics or stuff like that. And remember that when we train these people, at least for us, it's not just, that we're going to give a completion to any fellow. It's that the reputation of the institute is at stake. Anybody else who hires the fellow later sees the stamp of our organization and might just hire just based on that. So you can't send out somebody who's not up to the mark. So the goal is not to take punitive actions against the fellow. And even the best of fellows need to have a continuous engagement and feedback. This is what we have noted. Just because they're good, we can't just leave them alone. Then they'll not progress, or they may get complacent. So however, I would say that one big drawback is that the faculty has to be very, very involved and literally selfless, give a lot of time, at least to their mentees. So that is the commitment that the faculty has to have with this model. That's all, and I think all of this, as you said, you put out somebody who's so well trained, and that will help us in patient care, and we can hire those same people back with us also. Thank you very much.
Thank you. Thank you so much, Dr. Soma. Actually, LVP is a dream institute, and I think every mentee would always dream of being in an institute like that with such a structured program. So, and I wish all the hospitals, like especially the government hospitals all over the country, should follow such structured programs, irrespective of which department they are in, but at least they should get the good infrastructure and proper equipment and the right techniques for their fellows. Thank you so much.
Thank you.
Thank you. Dr. Samar sir, you want to say something?
Yeah, right now in the lunchtime, a girl come to me and said that I want to do fellowship. She is from some other state. So this question I asked every fellows during interview, that what is your plan for next 5 years? The answer actually depends on, though I do not have any gender variation, but for girls and for boys, the answer is different. And I know some of the girls, they have done beautiful fellowship program. They went back to their place, worked for 6 months with some institute or colleagues, and again after marriage, they have shifted to some other place where there is no facility for cornea. Cornea is such a difficult subject. It depends on eye banking proper. So it is, though it is 15 or 20% of your cornea work, but that is the end product of your, you are just incomplete unless you do transplant surgery. So I feel sad for them. So I answered her that you first decide, then you do an application in my email. So this is maybe relevant for all institute, especially with keratoplasty, unless you have, because unless you have little bigger umbrella, you cannot do transplant surgery alone. There are only 1 or 2 examples in the country who are having individual transplant center.
Yes.
So that is the
Right,
thing I wanted to share.
Definitely, sir. Thank you so much. Sir, want to
another
share
very
something?
important aspect which we have not covered is, see, most of these fellowships involve surgery, but not every trainee is cut out to be a surgeon. So many times I find that even after like 1.5 years of fellowship, there's some people who just cannot pick up surgery. However much time you spend with them, try to do it. So some are not cut out for surgery. So probably it's also the role of the mentor or the trainer to see as to who is cut out for that work. Otherwise, it's like trying to fit a square peg in a round hole, and it doesn't. Because see, in Europe, what they've done is they've clearly divided ophthalmology into surgical ophthalmologists and medical ophthalmologists.
Yes.
Because
I wanted to say that only.
Because they found in a study that a person who does like 100 or 150 cataract surgeries a year has much more complications than a person doing 800 to 1,000 cataract surgeries a year. And a person who is doing 1,000 cataracts can even do more with less complications. So they've clearly kind of divided. So you have non-operating ophthalmologists and operating ophthalmologists. I think even for the fellowship, we need to kind of look at who is competent for what.
But it would be a little difficult for the for the trainee to listen to that and to accept that fact.
But
it would be a little disturbing for that.
Another honest confession that cornea transplant is such a surgery. During fellowship period, everybody is euphoric, and when they go back to their practice and they do start cataract and refractive, they do not want to do the transplant surgery. I am telling you, in Kolkata city, there are 6 surgeons from Premier Institute. They have spent 2 years, 1.5 years, 3 years fellowship. When they come, दादा आपको पास भेज देते हैं, आप करो ना, आप तो बहुत करते हैं और एक बढ़ा लो. You do, I will supply the cornea. No sir, उतना head में नहीं लेना है. So the transplant surgery is such, you have to take the whole thing in your head. Unless that commitment is not there, normally I say you are not fit for, you go. I say that my condition is I will observe you 3 months. If I feel that you are not taking responsibility, go back to your place. So that is true.
One of my professors, corneal surgeon, he used to say that, being a corneal surgeon, you have to be very philosophical, because you will have to face a lot of failures. You will get secondary glaucoma, you will get graft failure. Yes. It's not like cataract or refractive surgery. It's not everybody's cup of tea, because otherwise you get depressed, in the sense that you're not able to give the same kind of result, outcomes and this thing. So you have to be philosophical about it.
Sometimes we get very different requests also. When I was interviewing one student, he came from one of the states which is not having a very good health infrastructure, and he made it very clear, and he was already almost nearing 30, and he made it very clear, I am working in a charity hospital, and in our area the corneal problems are more, corneal ulcers and other things are more, and we don't have any trained corneal person there. So my mentor, my chief asked me to go and do a corneal fellowship, especially in this institute, so that the clinical volume is more. So I want to learn mainly that, and whenever a ulcer problem occurs, to do a keratoplasty. So he's made it very clear, my aim is not refractive surgery, not this thing, but I want to go back and I have to start a proper cornea clinic there.
So that's a very focused way of thinking. That's so true.
Actually, we have to give preferences to such.
They say a good surgeon should have the heart of a lion, eyes of an eagle, and the fingers of a lady, but no gender bias here, but that's what they say.
Many of them even change this. We have seen a lot of retina surgeons who are now mainly doing cataract and refractive.
I think the glamour is more in cataract refractive, and that quick satisfaction of the patients in retina.
The money.
Yes. Okay, Dr. Radhika, ma'am. Yes. Dr. Radhika Natarajan, please inviting you for your talk on sustaining the intensity and consistency. I think over the years, people change what they want to do finally. Dr. Namrata Sharma.
Good afternoon, everybody. This is Radhika from Shankar Netralaya. Instead of feeling bad that in a late afternoon meeting we are having less audience, I'm choosing to think that, we are in a closed focus group kind of meeting that, makes everything feel even more special. We have had so many, it's a different perspective that counts basically, just like with the Cornea Fellowship. So basically we've had so many stalwarts giving us so many inputs. So what I'm basically going to do in very little time is to share snippets of my journey in dealing with Cornea Fellows regarding their teaching, their training, and more importantly, what Dr. Chitra told me. Thank her for inviting me over here. What we can do to maintain the tempo of the fellowship. I think Dr. Somshila has already elucidated that there are some main, components to the fellowship. Academics being the first, then comes the clinical aspect, then the surgical training, and last but not the least, research. So when the fellows come to you, they have just completed their post-graduation, and they feel the education is complete, and they're raring to go. They've heard of compartment corneal surgeries, they've heard about premium procedures, and they want to take a shot at all of that. But then it is up to us to get them rooted and establish the connect between the textual material and the clinical connect. For example, here was a patient, I'm sorry, this is not a clinical talk, but clinical context is a language that we all understand the best. So I am going to link that also. This is a fellow's patient. She came to me saying that this patient has corneal decompensation and I'm due for learning my DSEC procedure. So can I take it to a DSEC mentor to do the case? So when you take a look at the patient, there are two red flags over there. There's a localized corneal edema. There is aphakia and also a sector iridectomy. You look up, you see a grizzled old patient. This is Brown-McLean syndrome. So she did not know that this is an olden type of cataract surgery which somebody mentioned, that people have done earlier. And this is a very localized form of edema, not because of any corneal problem, but because of handling that goes on in the section, very much self-limited, and this patient doesn't even need a transplant, which is a procedure which should be done when nothing else is possible. So what the mind does not know, the eye will definitely not see. So that is the connection that we help them to establish even before they get their so-called, cutting chances. And this kind of coaching has to be done in a very casual and interactive manner. We must remember that these are fully mature adults with their complete training in post-graduation. So we cannot be just, calling the shots or, chiding them or ridiculing them in general. We should always praise them in public and penalize them in private, because we do not want a toxic learning environment. Why? It's not only for them, it's for us also. Like somebody pointed out, they are our ambassadors in the future. What they do reflects on us as an individual and as an institution also. And we may need them later for our patient follow-up. So it's best to inculcate that bond very early in the beginning itself. So it's for a mutual benefit. And I also feel, I say this in the best possible way, that a fellow is like an academic app. He or she will gather all information regarding patients, references, clinics, pictures, everything. And when you're at a free time, at your convenience, he or she is willing to discuss and take your opinion. So it is a refreshment of the learning experience from our side also. So we do benefit from teaching the fellows. Likewise, in clinics also, it starts off supervised and then they go on independent. So they should learn by example. We should lead by example. Here is again a case of a fellow who handled a patient during her night trauma duty. This is the other eye. The eye which she handled, the cornea was coming out in pieces. If only the history was taken properly, the patient did come out with history of pathological fractures. And if we had taken a minute to look at the fellow eye, you can see very clearly the wafer-thin cornea and the blue sclera over there. Then the possibility of a brittle cornea would have dawned on her, and she would have been more prepared both with tissue as well as consultant support, for this particular case. So documentation in the order that I've written over the history, symptoms, signs, it's not for anybody else. It's for us to recap later what we saw in that patient in the earlier visit should be inculcated in the beginning itself. It doesn't come later if you start haphazardly in the beginning. Like that, there should be a good handing over, taking over system. This also, we set an example for them that A passes on to B, B passes on to C, and then D doesn't even know who was A and what they started the treatment with. So each fellow, like the consultant, will be entirely responsible from end to end for that particular patient. And equal exposure should be given to the support specialty. They must be taught that an ASOCT or a pentacam is not some numbers that you read off from a sheet. Starting from why the test is being done, whether the patient can afford the test or not, how the optometrist did, how the patient fixated or cooperated for the test, how many tests were taken before the interpretation, all goes into the decision making of ordering the next test, and they must have a ringside exposure to all of this. So surgery, again, they watch first, then they assist, and then they go on to do. But unfortunately, a wet lab approach is not possible to all specialty surgeries. So what I do with my fellows, for example, somebody did pterygium surgery last week. So I discussed with her, I asked her to do a dry run. So she showed me how and why the superior rectus should be taken, where she will open the conjunctiva. She made those little drawings, which I later improvised for her. You can even throw in some situations. If you touch the ciliary vessel and it bleeds under the pterygium, what will you do? And if it's a recurrent pterygium, how would you find out that the medial rectus is enmeshed in the pterygium fibers or not? So then when they respond, it's a cooler situation. And later when it actually happens, the familiarity will help them with the decision making on table. And somebody beautifully took us through, Sheetal beautifully took us through the gamut of how difficult it is to train people for refractive surgery, so I'm not going to go into the details of that. But in a principally cornea fellowship, too much of emphasis on refractive is not possible. These are fully sighted patients and very expensive procedures, but we can definitely teach them about the preoperative decision making and the postoperative problem solving, and the rest will sooner or later fall into place, because these are two very important components of learning refractive surgery. So one golden rule that I follow, which really helps with research training for the fellows, is that through the course of my posting, each and every fellow is encouraged to do either one presentation or put together one report. It could be a case report, it could be a case series, it could be anything that they please, also intermingled with what I do on a daily basis. If somebody turns up saying that, I have chance to go to this conference, it's 2 days to the deadline, I never encourage them to do an abstract submission like that, because neither the individual nor the institute benefits in any way because of that. Now, you've seen these patients, you're putting it together for the joy of it. You have me at leisure to, go over your work. And later when it consolidates into a presentation or a publication and you see his or her name in print, then it's an exhilarating experience both for the student as well as for the teacher. So this is what we want for them and we do for them. Do they also want the same thing? I try to record it in their voices. Let me see if it plays for a minute.
Okay.
Yeah.
So Sridhar, you have finished 4 months of your training here now. Why did you choose Shankar Nethralaya to pursue your cornea fellowship program?
Shankar Nethralaya offers a comprehensive cornea fellowship along with refractive and ocular surface exposure. And the fellowship offers a good clinical and surgical exposure. That's why I choose the fellowship here.
Okay. So Priyanka, you have finished about almost 8 months of your training here. So I have 2 questions for you. One is, what do you expect from this fellowship program? And at the same time, what do you want to give into this program?
Okay, I would like to learn the skills which are required in my subspecialty which I've chosen, so that I can be confident and be independent in doing any procedure in my specialty. and to give to the institution.
So basically, they did echo most of the requirements that we had pinned for them. So for lack of time, I'm forwarding this video. But the one particular aspect which is never factored in formally into any curriculum, not only Cornea Fellowship curriculum, is the development of soft skills that also somebody mentioned earlier. So how to talk to the patient, how to talk to colleagues, how to talk to paramedical people. That's very important. If your secretary or your optometrist is not happy with you, then your life becomes difficult. In turn, your patient's life becomes difficult. They should not have that I'm the doctor kind of attitude, because there are support staff who have been there for longer years from whom even we can learn a lot of things, not only our fellow. And last but not the least, I always strive to inculcate a little bit of common sense in them, because there is a patient, again you can see over there, that a patient was referred to this fellow as herpetic keratitis. There are a lot of little KPs over there, and the fellow came to me asking whether we can start oral antiviral treatment. But if you take a closer look at the cataract, a cornea fellow does not mean he or she will see only the cornea. If you see the cataract, that is a flocculant intumescent cataract. What kind of viral keratitis produces a flocculant cataract like that? We go back and ask the history. The patient gave a vague history of blunt trauma. So this was phacogenic uveitis with cataract, where the arrow is pointing, you can see a little breach in the capsule. Why should we know the difference? Why should she know the difference? Because if it's a viral keratitis, the eye has to be quietened before this cataract can be removed. But for phacogenic cataract, you have to remove the cataract, only then the uveitis or the glaucoma will subside. So therein comes the difference, and therein comes in the need for common sense. So that lateral thinking is something that you always encourage, so that they can tie up the loose ends in their own practice. And they should always have the sense of purpose, that they have come from very far, and they should be focused on the fellowship. They should not lose time on other youthful diversions. So a little bit of course correction now and then is required. The best form of assessment happens in the clinic. Tests and viva do help. Prize exams, they create a festive environment. They pick out the best talent, and the prize giving ceremony also becomes a social occasion. But like somebody pointed out, apart from the prize fellow, the certification finally, after all your efforts are put in, I'm pushing for this, should have a difference in category between a fellowship with merit and a fellowship without merit, because there are some people who just go on doing what they want to do irrespective of the best of their efforts. So they should have a catch which will make them work a little better and come on par with the people who take the fellowship seriously. So putting a small with merit and without merit on the certificate, nobody wants to take a certificate which says fellowship without merit. That will make them work a little harder. So last but not the least, the fellow's life is a cycle of metamorphosis. They come in the egg stage. They've absorbed all the nutrient material of education, and they want us to polish them. When they come to us, they're in the larval stage. The larva is eating all the mulberry leaves like that. The fellow is voraciously looking for academic exercises. You can recognize that face. They say, yes, ma'am, multiple times before you finish a sentence. So that's the best window for you to get any academic activity done out of them. After that, you cannot catch them ever. A year down, they go to the pupa stage. They're a little dormant. They've learned a little bit of the ropes. They still do what is expected out of them, but they kind of fly below the radar. They'll come if summoned, but they're not that enthusiastic anymore. And then comes, this is not the butterfly stage, mind you. There is a Darwin-defying stage in the life cycle of a fellow, which is the stage of senior residency. That is the time they feel that they know everything, and they're willing to ask the consultant a thing or two. They feel that the classes are not meant for them. You have to be a little careful at that stage. You have to correct them as required, but you should not break their confidence. And then they become beautiful butterflies, and then they fly out. They are a little overwhelmed because they lose your protection, but they unbox their careers and become full-fledged professionals. And mind you, the bond between the alma mater and the alumni never suffers because of this. And we continue to grow as a closed community benefiting all our patients in general. Thank you very much.
Thank you so much, Dr. Radhika ma'am. That was